sorry about that. I paused the lecture and it finished on me. So this lecture is going to occur in 2 parts. And obviously you have found part 2 in Blackboard. So as I was saying about HIV, there are some people in society who have a higher risk. And those people include those who already have STIs, people with blood disorders, health problems in pregnant women, and of course there are some high-risk behaviors that can increase the transmission rate of HIV, including not using a condom and sharing needles with other people. Now, HIV from the very beginning has been a stigmatized disease. As it says in your text, it has been both medicalized as a disease and moralized as stigma. And we're going to look at the impact of this on the transmission rates in just a moment in both the Australian and the American context. Now, your text identifies that there's 3 layers of HIV stigma, which have a very profound impact on health. The first is self-stigma, the shame and self-blame of individuals as they realize they have the disease and they cope with the effects of it. Perceived stigma, there is a fear that disclosing their HIV positive status will lead to stigmatization, and this is indeed a very real fact in many countries around the world. Enacted stigma is when the discrimination is perpetuated because of actual or perceived HIV status. So there are 3 layers of stigma affecting people who are HIV positive. Now, the early health campaigns about HIV instilled a lot of fear. I don't know if you're familiar with the Grim Reaper advertisement, but there's a YouTube link there, and I encourage you to pause this lecture and go and have a look. It gives me the shivers watching it. It's absolutely terrifying, and then the smoke going through the advertisement as well. It scared the daylights out of people. Now, you may think this is effective because they need to be scared into good health behaviors, protective health behaviors. However, it's interesting to note the communities that are identified in the video. Indeed, it seems to target homosexual people and intravenous drug users, as well as trying to give the message that HIV is now among other groups of society. To me, it feels like there is a laying of blame quite clearly in the video. So fear and blame. And the result of some of these public health campaigns is the further marginalization of those 2 groups in particular, but anyone who had contracted HIV. Now, I went on a website to look at contemporary AIDS campaigns, and here are 3. Again, you can see the one, AIDS is mass murder, AIDS is a mass murderer, is quite a disturbing image, and it is clearly identifying, again, it is there to scare people. The one with the Superman and Wonder Woman there is a way to say that no one is invincible. We are all, we could all contract HIV, and that it is an equalizing illness. It doesn't matter who you are, where you come from, you can contract HIV. And then the computer one. Now, I do warn you, if you go to that website to look at some of the campaigns, it is very adult material and quite disturbing. But you need to make your own judgment about looking at these global campaigns. So there's been a lot of fear about the disease, a lot of scaremongering about HIV, and this has had a profound effect at how we look at it, However, let's get a different picture. What is actually happening with transmission rates? Who are the people who are being most affected by HIV today? Well, according to UN AIDS, here cited in your text, 33 million people in the world were living with HIV or AIDS in 2007. I checked this morning, the same organization as of 2011 has said that this number is now 34 million. Of this, 30.7 million are adults, 16.7 million are women, and children under 15 account for, I don't have that statistic here. Newly infected people with HIV this year, in 2011 was 2.5 million. AIDS deaths in 2011 was 1.7 million. These are huge figures. Now, globally, you can look at the diagram here. It gives you the male and female distribution of the disease across the world, and the size of the people indicates the size of the number of people suffering. Clearly, you can see the greatest burden is in Africa. but it is still significant in a number of different places, India and South Asia, but also in other places. When you look at it there, Australia has a very small set of people, and we'll find out why in just a moment. The diagram below gives you again the statistics broken down by male and female in different parts of the world. Again, it is quite clear that sub-Saharan Africa carries the greatest burden of HIV worldwide, and there you can see it is women who carry the greatest burden. 62% of people with HIV in Africa are female. Now globally, HIV is more prevalent among stigmatized groups. Yes, we've said gay men, injecting drugs users, and sex workers. But it is also more prevalent among marginalized groups, and this could be entire communities or groups within a community or entire countries that are marginalized vis-a-vis other groups. So poverty increases marginalization, and as we see here, women constitute a marginalized group globally, and in almost every, no, not in everyone, but significantly in South Asia, Africa, in those two areas in particular, which are actually the largest populations globally, again, it is women who carries the greatest burden. But even in places in the world where it seems that there is a lower rate of HIV, there is still a high cost, and it is still a major public health concern. For example, in the United States, AIDS remains a leading cause of death among people 25 to 44 years of age. Now, so I'm going to look more closely about the relationship between stigma and health, and stigma and HIV in particular. And the case study for this, this week is looking at sex workers. However, I want to draw your attention to an interesting case study from your text. And here it is not stigmatized behaviors or a stigmatized group of people who are suffering from HIV. Rather, it is a different set of social determinants of health that is causing the transmission. So I encourage you to have a look at Tuvalu, the case study in Vaughan. So what has happened in Australia with HIV? Well, the first case was discovered in 1982, and the annual number of diagnoses of HIV in Australia peaked around 1987. There was a decline, a visible decline from 1988 to 1999. However, at that point, rates again began to rise. The annual number of AIDS diagnoses in Australia peaked in 1994. So here is a chart that gives you a visual depiction of AIDS rates, 1981 up to 2007. So the blue graph shows HIV and the red shows AIDS. And you can see indeed around 1987, HIV diagnoses began to drop, and it continued to drop until up around 1999 and then began to rise significantly. For AIDS, however, it has a slightly different pattern, and it is around 1994 that it peaked and began to decline after that. And in fact, the numbers there have continued to be quite low. Why is this the case? What has been the Australian response to HIV? Well, in fact, Australia has been recognized internationally for its success and the way it has approached the disease, the way it has managed it, and the Australian approach has been a model for other countries. One of the main reasons for this is the reduction of stigma around the disease. Very early, Australia tried to reduce the stigma, tried to increase access to treatment and testing for the public. And what has been characteristic of the Australian response from the very beginning is a close partnership between non-government organizations, the government, and people, civilians who have been affected by the disease. And again, that highlights what I discussed in Module 2, Healthcare Delivery, the strong role that health advocacy and NGOs play in health change. By international comparisons, Australia continues to have a relatively well-controlled HIV epidemic, contained by and large to gay-identifying men. So the approach to HIV in Australia has been informed by a human rights approach, and I encourage you to look at the Ottawa Charter to understand that approach. It allowed for a high level of consultation and collaboration between groups in partnership to prevent, manage, and treat HIV/AIDS in the community. And this also draws on a primary healthcare approach, drawing on community resources to address health concerns. Some people have argued that both the strategies and the partnership has been watered down in recent years, and certainly the sudden upturn in HIV transmission should cause us to ask some questions about what we're doing now. Particular questions have been who is participating in decision making and delivery of services, to what extent do communities have ownership over HIV services, how is the government providing leadership, and how much investment is being put into the management of HIV? And see, these are some good questions. The program response to the HIV epidemic is largely carried out by state and territory health departments and community-based organisations. Again, because Australia's healthcare system is managed both by the Commonwealth and by state governments, there is some complexity there in terms of approach. Since the year 2000, there's been a divergence between the way different states handle HIV. And as Sharon has said here, it creates a natural experiment in HIV prevention because we can now start to look at the differing statistics by state to find out which approach is the most effective. Now let's turn to the United States, because there is a higher rate of HIV and there's been a very different response to the disease. Now it was discovered in the 1980s. And it became more prominent in the 1990s. And at this time, Ronald Reagan was the President of the United States. The initial response of the Reagan government was homophobic. This disease was thought to be, was linked to the gay community, which was a stigmatized community. The United States has a very strong conservative population, and there was a labeling of this disease as a gay disease. And so therefore, the Reagan government distanced itself from it. It did not act quickly, so it delayed action throughout, in fact, most of the 1990s. And indeed, there's a concern always about your votes. If you're seen to be providing money and support for homosexual men, intravenous drug users, and prostitutes, it would be difficult to achieve re-election. In addition, testing was not as affordable or widespread, and so a lot of people were transmitting the disease and not realizing that they were carrying it. And also, in a very conservative country, the lack of sex education in schools also meant that people weren't talking about condom use, safe sex, communication, sexual health across the board. And indeed, we also saw earlier that there's a link between sexually transmitted infections and HIV transmission. So if there is a prevalence of those diseases because there is not as much awareness, discussion, and access to services, that's going to affect the HIV transmission as well. There were travel restrictions on people with HIV positive status, and treatment was expensive. And in fact, we've seen globally a great reduction in the cost of antiviral, of the drugs used to treat HIV and AIDS. So the result of this, of course, was a higher rate of HIV in the American population, and a delayed response and an increased stigmatization related to the illness. So let's turn back to Australia. Obviously, Australia has had a positive response, a coordinated response to HIV, but we're seeing the numbers going up. What is the current picture of HIV/AIDS in Australia? Well, the current high-risk groups in Australia are men who have sex with men, commercial sex workers and homeless youth, prisoners, Indigenous Australians, intravenous drug users, although this is reduced dramatically, and people who acquire HIV overseas. And it is that last group that we're going to be looking at here. So the challenges. Well, the groups of increasing risk in WA are mainstream, and as we're going to see, it is heterosexual men, businessmen who are traveling to Asia for business and tourism. That is a significant cause of HIV transmission. This is not necessarily a marginalized group. However, other groups are hard to reach, such as homeless youth. They're difficult to find. They may be distrustful of services. They may not have the same access to services. Growing prevalence in Aboriginal and Torres Strait Islander population, and here there is a very strong fear of disclosure and discrimination. And as earlier lectures have discussed, there is also a lack of cultural safety and healthcare provision to Aboriginal and Indigenous people, which means they are not coming in and receiving the level of healthcare that they need. Prisoners are indeed at risk, yet policy makes harm minimization strategies difficult, and that is a different context that I'm not going to be looking at here. So what is the influence of social norms on stigma and HIV? Well, as we talked about earlier, norms are ways of communicating to people what they should do and shouldn't do, right behavior and wrong behavior. And there are a number of different groups in society that help us form our attitudes, values, and beliefs, and who help perpetuate social norms. So parents have a huge influence on how we think and how we act. Our peers, our religious affiliations, cultural beliefs, etc. Now, as was noted earlier, social norms may not always depict positive behavior, and social norms may change. Now, last year I went with a group of nursing and midwifery students to Thailand, and we went to the Chameleon Center, which is a initiative started by the Catholic Church, helping people with HIV/AIDS in Chonburi. And in the top slide there is a picture of some art that children, either children with HIV or children whose parents died from the disease, they've been orphaned because of HIV/AIDS. And in the bottom is a chart of the medication there and the very needed drugs to treat HIV/AIDS. But what happened is that the Thai government, and in fact the very, very respected monarchy of Thailand, decided to tackle the stigma. And it is very interesting that in some places in the world, religious organizations prevent open discussion of sexual health and HIV/AIDS. In this case, the Catholic fathers were pivotal in advocating to the government that these medications should be available. They created this center where people could live and stay, and they strongly changed the attitudes in Thai society towards people living with HIV/AIDS. And because of that, there's been a significant change in the rates in that country, but also the lives of people who are living with HIV/AIDS or whose people that they care for are living with HIV/AIDS. So let's look at sex work. This is one marginalized group that is linked into current transmission rates, and it is significant for Western Australia, as you will see in the activities or tutorials for this week. Who are sex workers? Well, what we need to understand is that sex workers do not often choose to go into sex work. There is coercion. In the case of women and men and children in Cambodia, Thailand, Vietnam, India and other places, and indeed Australia as well, there may be coercion by family. Sometimes girls are sold into prostitution because the family needs the money. Poverty is one of the main causes. When there's not other opportunities for an income, women get pushed into sex work. Indeed, debt is another factor. Now, sex workers come from diverse backgrounds, and there's also diversity within this category called sex workers in terms of the levels of risk for individuals. In most places, they are not protected by the law because the government does not want to be seen to be protecting or supporting the sex industry and sex workers. So therefore, they are often stigmatized, marginalized, and criminalized for their work. Because of this, it is more difficult for them to access health information and to access legal and social services. And therefore, of course, this increases the transmission rate of HIV. So here is an image from Google Images in Cambodia of the Svay Pak red light district. And here girls 15 to 18 years, but often much younger, work the streets, 35% of whom were smuggled in from China or Vietnam. So here we see a link with human trafficking. And there's a very strong connection there between the process of trafficking, legislation put in place to prevent it, and the HIV transmission. Primarily, it is women, boys, and girls who are sex workers in this context. And the problem is that they are bound by contracts. The contracts cost up to, in American currency, $350 to $450. Now, they are told they need to pay for transport, the food that they have, clothing, medical costs, etc. And often what happens is that they are told by the traffickers that they owe them money, or by the brothel owners, or by pimps, and so they get caught in a cycle of debt. When each transaction pays no more than $2 to $3, you can see that they have to spend months or years, or perhaps they never pay off this debt. This becomes particularly evident when women turn to drugs or alcohol in order to cope with their life, and that increases the debt because they're putting their money into feeding the addiction rather than getting rid of this contract. In addition to this, there's often corruption in the government, and this may be the police, the judiciary, other branches, people who are setting health policy, and collusion with the industry. Let's face it, it's lucrative. And so therefore you get an element of corruption. Now, the most effective strategy is to partnership with NGOs and indeed to engage in primary healthcare. And if you have forgotten what I mean by primary healthcare, I encourage you to go back and have a look at some of the earlier lectures. As Mameli notes, vulnerability to HIV/AIDS exists when individuals are unable to make decisions about their health with full freedom and information. When governments, non-governmental organizations or NGOs, and the private sector, remember those three groups I talked about in Module 2, operate in partnership to safeguard human rights, the opportunity to lessen vulnerability to HIV/AIDS is at its greatest. So again, we need that partnership of those three groups to come together and provide primary health care, education, information, access. So when we talk about partnership, there's various levels that this can take place on. One that would be knowledge of and trust by the affected population. So you need to make sure that, let's say in this case, sex workers know what's available, they trust the people that are providing information and services, and therefore they're more likely to access it. There is research to be done, there is advocacy, and as I said in the case of Chonburi, Thailand, what the Catholic Church did was advocate a change in attitude and a change in policy, and the monarchy and the Thai government responded and drastically reduced the transmission rate. Number 4, creating and influencing various rights-related agencies and institutions. Drawing on last lecture 4, healthcare delivery, looking at values and human rights, the human rights discourse is very powerful in terms of advocating for change related to HIV, and therefore to change legislation and policy. So when it comes to sex workers themselves, what can we do to change the levels of HIV? Well, at its very basic, an increased use of condoms and safer sex among sex workers and their clients is going to be key. Now, the difficulty with this is that sex workers may not have very much control over their working conditions and the environment in which they work. And in fact, it's been noted in your text. Yes, Vaughn says, the risk of having sex without using a condom may be balanced against the risk of gender-based violence, the risk of not having enough money to feed children, and the risk of being alone. So, although it's very easy to say use more condoms, are they available? Are they accepted? Can women insist that their clients use them? How much are they paid if they don't use them? There's a whole bunch of questions there. Are they a good quality? In many parts of the world, the condoms are not made well, and so they break and are basically useless. There may not be enough of them, and in fact, in many countries, condoms are reused. They're rinsed out and reused. Well, this is not going to help reduce transmission. What's also needed is to reduce the number of STIs among sex workers as well. So some suggestions, what can we do? Provide condoms, educate sex workers and clients about HIV, encourage peer education, so that's people teaching each other about what they know, helping sex workers to work together, reducing the stigma that communities attach to sex work, ensuring that laws and policies respect sex workers' human and citizen rights. Now, it is a complex debate because some people would immediately say, well, this looks like you're supporting the sex industry, you're condoning it, and some people may have a problem with that morally. One issue is that this is not going to go away, and the more that it is ignored and stigmatized, it goes underground. People do not have the access, and the result is a higher transmission rate. And this was shown very clearly in the Sonagachi project. This was started in 1992 in Calcutta in India, and the aim was to help sex workers to overcome HIV/AIDS on their own terms. So they had this approach based on respect, reliance, and recognition. And in this case, condom use rose from 27% in 1992 to 86% in 2001. That's an amazing change. And it wasn't easy. In the case of in Calcutta, in this particular red light district, women live in brothels, and they are dominated by and controlled at the same time as protected and looked after by the madams or the brothel owners. But the districts they work in are not that safe. They also have to work with gentlemen's clubs, which is a form of social organization and kind of informal police system. And these gentlemen clubs control the district within which the madams operate. Then you had these NGOs coming in and the international donors, both of which had their own agendas. It was a very complex social situation in which to launch a project. And what they wanted to do was empower the sex workers to improve their health outcomes. And as you can see by the condom right, there was significant change. What the authors say is that interventions with sex workers are a cornerstone of India's response to the HIV pandemic, given that the majority of HIV infections are thought to be acquired through unprotected heterosexual intercourse, and that traditionally few Indian women other than sex workers have opportunities to have multiple sexual partners. The project began in Sonagachi, Calcutta's largest red light district, where an estimated 5,000 mainly female sex workers live and work. Economic poverty and social stigma characterize most sex workers' lives. Their working conditions are controlled by brothel managers, pimps, and local men's social clubs. In these unpromising conditions, the Sonagachi project was initiated with an HIV prevention remit in 1992. Now, what this article notes is that I mentioned the fact that aid agencies have a role to play in HIV reduction. And indeed, they often fund projects that are implemented by NGOs using primary health care. One challenge comes is that those donor countries have their own social norms, their own values, attitudes, and beliefs, and so therefore their own restrictions on policy. This article notes that US aid requires applicants for funding to have projects that have a policy explicitly opposing prostitution. And so therefore, this requirement is based on a principled objection to the sale of sex. So US aid would not fund this project, for example, because it is seen as supporting the sex industry. And this can be a challenge sometimes because they desperately need funding, and it is a difficult issue for many people morally. However, it is a vulnerable group, it is a stigmatized group, and there is a demand for the services that they provide. So what is the most effective way for us to help this group and to help reduce the transmission rates? You may want to look at an interesting film called Born into Brothels. And in this case, a woman went in and provided cameras to the children of prostitutes working in Calcutta's red light districts to understand how this stigmatized and very vulnerable group of children view their own world. So there's some links there if you'd like to find out more about that documentary. So what works? Protest and advocacy, we certainly saw that in the Thai context. Support groups, knowledge, because again, knowledge helps people get power in terms of their health outcomes. Social movements, community organizations, legal change, and public education. So in summary, marginalized groups are at greater risk of social, emotional, and physical health, including HIV/AIDS. Stigma results in an increased disease burden. Public health plays a vital role in reducing or increasing stigma. Now, Vaughan has 3 conclusions to make about HIV globally. It says, globally, the HIV/AIDS pandemic does not follow international political borders, but rather economic margins. The biological and behavioral factors that increase risk of HIV infection and many other negative health outcomes are in turn shaped by economic, political, social, cultural, and structural determinants. The interconnectedness of all peoples in our current globalized environment means the Australian community is affected by and should be interested in the health of communities around the world. And this last point is exactly what the tutorial for this week and the online activities for external students focuses on. You may think to yourself, well, whatever's happening in the red light district of Cambodia or Thailand, it's got nothing to do with me. Well, it does have to do with you. A Curtin study that we use as a case study for this week looks at the fact that one of the significant transmission sources in Western Australia at the moment is, as I said, men who go overseas for business. This is heterosexual men who go overseas for business or tourism and engage with the sex trade there, and then come back and infect their wives or partners in Australia. One of the challenges for this is that the women do not know that their husbands are not in a monogamous relationship. They do not know that they've been participating in the sex industry overseas. They do not know that they're at risk of contracting HIV, and they do not know that they're at risk of transmitting HIV to their children. There is also, therefore, a delay in getting treatment for people who are infected this way because of a lack of awareness of what's happening, and also a deep sense of betrayal when it is discovered that this is what has been going on. And so therefore, what happens in the sex industry in Asia, the coercion, the lack of access to the social determinants of health, the lack of power and knowledge of this vulnerable group of stigmatized people, does indeed affect people that we know, work with, love in Perth, in WA. Here are some references for you to look at to understand about HIV further. Thanks very much for listening.